Good evening, respected Professor Nagaswamy sir. My dear students, I welcome you all to the new session on physiological and basic sciences according to new batch of students needs. Today we will be requesting us to cover the topics on cardiac physiology. It will be a very interesting session onwards. We look forward to further sessions on basic sciences in this series. Over to Professor sir and my dear students. Thank you, sir.
Right. Thank you. And welcome to the new batch who are going to appear for their theory examination. After your seniors have completed their practicals yesterday and today. So we start with the basic sciences. Usually, if you see the textbooks available for learning the basic sciences, you have separate book for physiology for anesthetists. You have pharmacology for anesthetists. Good evening, Dr. Kalpana. Where are you from? Okay. And you have anatomy for anesthetists. You have physics for anesthetists. So all these books are separately written by so many experts. And we have been having such books right from my PG days. So instead of studying each and everything, for example, if you take anatomy for anesthetists, it will start with the anatomy of the respiratory tract right from the nose to larynx, trachea, respiratory passages, and the diaphragm. All these things will be included in the anatomy. And if you take anatomy of the cardiovascular system, it will include the structure of the heart, coronary circulation, the valvular apparatus, and all those things. And if you take the liver, it will show the hepatorenal system, it will show the liver anatomy, etc. So instead of studying the anatomy of individual organs, I thought combining the anatomy, physiology, pharmacology, and clinical implications of each and every system will be a comprehensive learning rather than studying individually about every organ as anatomy and physiology. So this attempt was made in the last series of lectures for your senior batch, and I was told that this was quite useful. So I have made a little more changes to that, and it will not be a didactic lecture, it will be an interactive session where you can answer the questions that are shown there, and we will proceed as we see those questions and try to answer those things. And you may have to learn something more from what is given in the books also by my collection from the experiences as well as from the questions that have been asked in the examination. So it is going to be a comprehensive one comprising of all the anatomy, relevant anatomy, physiology, pharmacology, and clinical implications.
Good evening, sir.
Good evening. You are Kalpana.
Yes, sir. I'm first year resident in Mute, sir. Newly joined.
Good. So any other new PGs? Can they just switch on their video and show their face? Because I hardly get to see your faces unless you start presenting cases and then switch on your videos.
They are going.
Good evening, sir.
Good evening. Aravind, I think you came to my house on Vaikunta Ekadasi day.
Yes, sir.
Correct?
Dr. Aravind. Yes, sir.
Right. Okay. Where is Akash? He didn't come?
Anish, sir.
Anish. Yeah, okay. Anish is not joined. Okay.
Yes,
Right.
sir.
So I'm very glad that the juniors have also joined. And so let us see how far our knowledge of the basics of cardiovascular system is there. Please be interactive and try to answer whatever answers you know, so that it will not be a boring single man's shouting. Okay. Thank you very much. I'll share my screen now. Are you able to see this screen?
Yes, sir.
I'll just go for the slideshow. So, as I said, the first thing, anatomy. Commonly, this question is asked in the theory examination repeatedly several times. Coronary circulation, anatomy of the coronary circulation is a oft repeated question in your theory papers for D&B. And all of us should have a good idea about the anatomy of the nervous conduction system of the heart. Then we should know the structure of the ventricular ventricle to know their function, and the peculiar nature of the cardiomyocyte structure. And this thing was not included in the last class, but today I thought of adding this also, because we get valvular heart diseases as a part of our clinical cases, where we get mitral stenosis patients or aortic stenosis patients or congenital valvular diseases patients like tetralogy of Fallot, etc. So I included this also this time. Then coming to the physiology, the basic thing about cardiac cycle. What are all the steps in cardiac cycle we have to know? Then we have to know about the cardiac reflexes. There has been one question in theory for basic sciences. Describe the various cardiac reflexes and their pathway, and how blood pressure is maintained. What is the role of pacemaker cell and the cardiac myocytes, what is the difference in their action potential, and how the cardiac function is controlled. What is the nervous system, that is autonomic nervous system control of cardiac function. These things comprise of the cardiac physiology. And in yesterday's OSCE exam also, for the seniors, Sanjita has messaged me that there was an OSCE on the pressure volume loops of cardiac cycle, and the pressure volume loop of various valvular diseases was shown, and they were asking the questions on that. So this physiology will help to understand that. Then with regard to the pharmacology, we must know what is the effect of the various volatile anesthetics on cardiac function, and what are all the sympathomimetic drugs that we are going to use when the cardiovascular system is depressed or stimulated, and what are the cholinergic drugs and their effect on the heart, antihypertensive drugs. And one more thing to be added, which I did not find time today because of some commitment, is the drugs acting on the coronary circulation. So that has to be added. Next class, I think I will add that also. So this is the basic format for the learning of basics of cardiovascular system. So we go to the first level, coronary circulation. Why the blood supply to the heart is called coronary circulation? Can anyone answer that question?
Because the heart is supplied by both right coronary artery and left coronary arteries.
Okay, then we can say it's a dual supply or a twin supply. Why the word coronary circulation? Otherwise, they could have called it as cardiac circulation because it is supplying the heart. But why the name coronary circulation has been given? Anyone who knows the answer can come out with the answer.
The
Okay, if you
supply
don't know, say-
resembles a crown.
Fantastic. The coronary circulation refers to the vessels that supply drain the heart. The coronary arteries are on the way to much like a crown of a king. Okay, this is the picture. So if you see these portions and imagine the way the coronary blood vessels are spreading from their origin, it almost looks like this crown, isn't it? Do you agree?
Yes, sir.
Yes, sir.
So this is the reason why it is called coronary circulation. Okay, so it is the picture of the crown. It is upside down, not the true picture. So this portion goes to the head, but this bent wires like things here, they resemble the coronary vessels in their anatomical nature. So that is why it is called. So the next question is, what is the origin of coronary arteries? Where do they? You said there are two coronary arteries, right and left. That's the correct answer. Where do they originate from?
Aortic
What is the
sinus.
aortic sinus and
Coronary. Aortic.
okay. So the arterial supply, heart is supplied by two coronaries. They come from the ascending aorta, immediately above the aortic valve, which is called aortic sinus. Okay, that is the location. And the coronary arteries and their branches run on the surface of the heart and being located inside the subepicardial fibrofatty tissue. So the pericardium is covering that and forming a protective layer. And they are also having blood supply of their own, which is called the vasovasorum. And these are not end arteries, but functionally they behave like end arteries. Even though there is a communication between the right coronary branches and the left coronary branches, but it is not like other collaterals communicating with each other. And they behave like, that is the reason why, unless you develop good collaterals other than these ramifications which are joining with each other, the incidence of ischemic heart disease is more because of this nature. Because they, even though they have some communication anatomically, functionally they behave like end arteries. That is, one vessel which supplies a particular territory ends there. There is no other branch coming and supplying that same area. But when you do some physical exercise like regular walking, they say that new vessel formation will happen on its own in that area, and that is how people who have a block in the major vessel sometimes do not suffer from ischemic changes or frank myocardial infarction because of the new vascularization that happens through that. Okay, so this is one point that you have to remember. And this picture tells you where exactly the vessels originate, and you can see this is the right coronary artery arising. I think this is the aorta. This curved thing is the aorta. So at the root of the aorta, above the aortic valve, is the origin of the coronary arteries. So it goes like that. It has got branches, and left coronary, it has a main stem, which is the small segment, which is called the main coronary artery, but immediately it divides into two major branches. What is the branch going down here? It's called
Left circumflex artery.
circumflex. It circumvents and goes in a circular fashion. So it is called circumflex, and this is called
Left anterior
anterior
descending artery.
descending artery. This is supposed to be the major blood supply to the left ventricle, and commonly this occlusion or any block in this left anterior descending produces the major impact, because left ventricle is the main chamber from which our cardiac output is supplied to the entire body. So any block in the anterior descending artery or LAD, as it is called, is a major concern, because that is the one which supplies the left ventricle. Now, which parts of the heart are supplied by the right and left coronary arteries? This is a very important anatomical knowledge, so that we can locate where exactly the ischemia or the infarction has occurred. So, can you name the parts supplied by the right and left coronary artery?
Right coronary artery by right.
Right ventricle.
Right auricle.
Right ventricle, posterior wall of left ventricle, and posterior part of the septum.
SA node also, sir.
Interventricular septum.
Yes.
Very good. And left?
Node.
Left?
Left
Major
coronary
part of
anterior
the left anterior descending supplies major part of the left interventricular septum and major part of the left ventricle.
Okay. 2/3 and 1/3.
Of the
So saying major, you can say left coronary supplies 2/3 of the interventricular septum, and right coronary supplies 1/3 of the posterior, especially posterior 1/3 of the the interventricular system. And right ventricle is supplied by right coronary, and left ventricle is supplied mainly by left coronary arteries. Okay. So left coronary artery has two main branches, which we saw, LAD and circumflex. So it supplies the left atrium, left ventricle, except the area adjoining posterior interventricular groove, and right ventricle adjacent to the anterior interventricular sulcus also, and anterior 2/3 of the interventricular system. SA node is normally supplied in 65% of the patients by right coronary.
coronary artery.
Occasionally, in 35%, it may be supplying the. And what is the significance of the SA node blood supply? Supposing it is supplied by the right coronary, what will be the clinical evidence to detect that it is right coronary occlusion? What will be the heart rate in this patient if the SA node is ischemic?
Sir, junctional rhythm, sir.
Functional rhythm.
Junctional rate, first of all, rate. What will happen to the rate?
Bradycardia.
Bradycardia.
Okay. Any patient complaining with anginal pain coming to the emergency room, and he has evidence of sweating and other features. If pulse rate is low, you have to suspect right coronary occlusion. On the contrary, if the patient has a left coronary occlusion, heart will try to improve the cardiac output because left ventricular supply is diminished in left ventricular occlusion. So heart will always, whenever there is a decreased cardiac output, what will be the response? Hypotension. What will be the response?
Tachycardia.
Tachycardia. Okay. So if there is tachycardia, it should be left coronary occlusion. If it is bradycardia, it should be right coronary occlusion because majority of the patients receive supply from SA node. So this is one important finding, even though it is a very simple test to count the pulse rate of the patient, that can give you a lot of clue about the origin of the ischemia or infarction in clinical scenario. Okay, so that is the one thing that you have to remember. So this is again the picture that is showing, and the right coronary supplies the right atrium, right ventricle, SA node as well as AV node. So that is why if SA node is very badly admitted, AV node will take over, and somebody said junctional rhythm, that also that we can detect only by ECG, but not clinically. So pulse rate is the main important thing, and the intraatrial septum, portion of left atrium, all these things are supplied by the right coronary. So in the exam, you have to write about these areas which are supplying. And this picture you see, what is this picture?
Coronary angiogram.
Angiogram. Yes, very good. So this is the coronary, left coronary angiogram showing the proximal LAD. Even though you see pictures are showing LAD like this, angiogram usually the LAD will go only like a circumference. Okay, and this is the this is the proximal LAD. This is the bifurcation where the circumflex and the LAD are dividing, and this distal circumflex. And all these pictures you should get familiarized, especially if you plan to become a cardiac anesthetist. You should know how to read a coronary angiogram and find out whether there is any block or not, whether the peripheral flow comes up to the tip. That is a very important thing. In case there is a block in any of this area, you will find the dye will not flow distally, and you will find a opaque block at the level of the occlusion, and distally the dye will not flow. It will all be very pale white curved lines. So that is how you find the occlusion, and then they give the report. Now, coming to the next important point, everybody should know what is the dominance in coronary circulation and what is its significance.
Depending on the origin of the posterior descending artery, sir, whether it's originating from the left coronary or the right coronary artery.
Very good. And what is the significance of that? That answer is correct. Why should we know about this?
The posterior part of the left ventricle is supplied by the posterior descending artery. So in case there is a right coronary artery occlusion or a left coronary artery occlusion, the posterior base of the ventricle will also get affected.
Upset. Okay. So coronary dominance is based on the vessel that gives rise to the posterior descending artery. That answer is perfectly correct. It supplies the atrioventricular node. It supplies the AV node. Okay. And it's recognized by the presence of central perforating branches arising from right coronary in 80%. Majority of the population will have only what is called a right coronary dominance, and from the left circumflex in 10%. and the rest 10% will have supply from both right circumflex, right coronary artery, as well as the left circumflex of the left coronary artery. Both will supply the portion called the posterior, will give rise to what's called the posterior interventricular artery. And if both of them are contributing a branch, that is called codominance. So these three terminologies are important: right dominance, left dominance, and codominance. So majority of the population will have only right dominance. And this hand-drawn picture will give you a good idea about the right dominance. 2/3 of the population, posterior descending artery comes from right coronary artery. And see, this is the dotted line is the posterior descending artery, and that arises from the right coronary artery. Left dominance means you will have to get the supply from the left circumflex. That is again the posterior aspect, so it is given as a dotted line, and both of them are supplying the AV node is situated here. Okay? And codominance, both of them will give rise to the thing. And these are all the branches of these two arteries. That is, the left descending artery has got a diagonal branch as well as septal branches. 3 diagonal branches are there: D1, D2, and D3 as they are called as they come down. And there is the septal branch S1, S2. And septal branches for posterior is supplied by the right coronary. So this green thing are the septal branches from right coronary, which arises from this particular thing. So the clinical importance is, if it is a left dominance, a block in left coronary artery will affect the entire left ventricle, interventricular septum, while in right or codominant cases, a block in right coronary artery at least will spare the 2/3 of the septum. That is, the anterior part of the septum will be spared, and left ventricle also will be spared. So that is the importance of this particular dominance. So if the right coronary dominance is there, it is a good thing or bad thing?
Good thing.
Good thing for the heart, because the left ventricular function will still be preserved. Okay, so that is why nature has given that 80% can be saved. Even if you develop a right coronary occlusion, left ventricular function will be still be preserved. On the contrary, if you are unlucky and if you have a left coronary dominance, your left ventricular function will be affected, and you will end up with acute shock with hypotension and severe tachycardia to compensate for that. So it is very risky to have dominance by left coronary supply for the coronary blood flow. So this is again a pictorial description of what is the dominance. Now, which area of the heart is called a crux, and what is the importance of that? Idea? Okay, so let us go to that. Crux is nothing but the meeting point of the interatrial groove, posterior atrioventricular groove, and posterior interventricular groove. Okay, so imagine interventricular groove. Interatrial groove means it is a groove between the two atria, and posterior atrioventricular groove means it is a transverse groove, and posterior interventricular groove. So imagine a line from here, a line across, and a line down. So what does it signify? That if you imagine a line like that, it looks like a plus mark or a cross, isn't it? So you imagine there is a groove on between the two atria. There is a groove horizontally, and there is a groove vertically again below. So it looks like a plus mark or a cross mark, isn't it? So that's why it's called the crux. Okay. So the atrioventricular nodal artery, it supplies the AV node. This runs close to this particular point. So surgeons use the crux as a guide when operating on AV node or surrounding structures, and any abnormalities in this location or structure can give to maybe an indication for congenital heart disease or heart defects that can be present from birth. Now, what are the types of anterior descending artery? Because this is the major supply to the left ventricle. When you, I don't know how many of you have read the angiogram reports of patients who have undergone coronary angio. They always mention the left anterior descending. This is the type of artery. You know how many types are described as per the angiogram, and what is its importance? Okay. So depending upon the length of the LAD is classified into 4 types. Okay, type 1, type 2, type 3, and type 4. So type 1, the vessel runs up to this, but does not go to the apex. So it's a very short vessel. So it will come like this. It will here it is showing the posterior interventricular sulcus. But for your imagination, I'm just showing you. Imagine this is the LAD. It will come up to that, but it will not go to the apex. Then it is called the type 1 vessel, and type 2 supplies the part of the apex, and rest of the apex is supplied by the right coronary. And type 3 is the left anterior descending itself supplies the entire apex. And type 4 supplies apex plus also some portion of the inferior wall of the ventricles on the posterior side also. So that means this type 4 vessel is the longest, and type 1 is the shortest vessel. And this is how this picture tells you clearly. You can see the left anterior descending stopping short here. So it does not reach the apex. There is a dual supply in type 2, both LAD and the RCA supplying. Type 3, you can see the entire length of LAD going up to the apex. And type 4, wrap around. The LAD supplies not only left ventricle, or also goes to supply 25% of the inferior wall. This anatomical knowledge, rather it is the description given after, you can find it only after an angiogram. Okay, this tells you about the feasibility of putting a graft. So if it is a supply, dual supply, if there is any difficulty in putting a graft here, you can supply to the right coronary also, which will go and supply the apical portion. Otherwise, the apical portion will become hypokinetic. And you will see in the next few pictures why apical contraction is very important for the cardiac output. Okay, so remember these 4 types. It is based on the length of the LAD, and this is purely a description given in coronary angio reports and not a clinical report. Okay. Then comes, whenever there is an arterial supply, there should be a venous drainage. So what is the veins which directly drain into the heart called?
Coronary sinus.
Majority of the veins will drain into the coronary
Sebacean
sinus.
veins, sir.
Thebacean veins, anterior cardiac veins, and venae cordis maniae, or the minimae, or the Thebacean veins. These are the 2 veins which directly drain into the ventricles, right ventricle and the 4 chambers of the heart. So there are small veins, 3 or 4, which run parallel to every other across the surface of the right ventricle to open into the right atrium. So the anterior cardiac veins directly drain into the right atrium, whereas the venae cordis minimae, otherwise called the Thebacean veins, they are also very small veins which all drain into all the 4 chambers of the heart. So these open directly into the respective chambers, and these are most numbers in the right atrium also. And what is the significance of these Thebacean veins? Do they drain oxygenated blood or deoxygenated blood?
Deoxygenated blood. Physiological blood.
So this forms, if they are supplying a larger volume of deoxygenated blood, what will you call it?
Physiological shunting.
Shunting, yes, excellent. So it is the shunting that can happen in case this flow is very heavy. Okay, otherwise it is quite insignificant. That very small amount will be draining into that. So don't make a mistake if the question is asked as veins directly draining into the heart. Whereas the main venous drainage of the heart, which are all the veins?
Great cardiac
Cardiac
vein,
vein, middle
small
cardiac
cardiac
vein,
vein, middle cardiac vein.
coronary sinus.
Very good. Okay, right. So the coronary sinus is the main vein of the heart located on the posterior surface of the coronary sulcus, which runs between the left atrium and left ventricle. Okay. The sinus drains into the right atrium. Here all the venous blood is drained. Nature has provided it because it is a deoxygenated blood. It goes to the right atrium, and within right atrium, the opening of the coronary sinus is located between the right atrioventricular orifice and the inferior vena cava orifice. So why should we know about this drainage or coronary sinus? Why are we bothered or why should we have a knowledge about the major venous drainage of the heart? Any clinical application to this? When you do a open heart surgery?
Cardioplegia, sir.
Fantastic. Cardioplegia, retrograde cardioplegia. You can supply cardioplegia through this also, antegrade and retrograde. If you supply it through the coronary arterial supply, it is called antegrade. Then insert a catheter as you are doing in a standstill heart. You can identify the opening of the right or left coronary, insert your catheter into that and supply the cardioplegic solution. Rather, if you have with any difficulty, you can insert the same catheter into the coronary sinus and supply the, because if the vein is a drainage one, artery is a supplying vessel. So it will have a forward flow and this will have a retrograde flow through which it will supply the cardioplegia. Now, what are the tributaries draining into the coronary sinus? There are a lot of tributaries. Great cardiac, middle cardiac, small cardiac, like that. So these are all just veins which should not be damaged during any cardiac surgery. That is the purpose of that. But this is the main important clinical application about the coronary sinus and Thebesian veins. Okay. Now, usually we use a 12-lead ECG to determine the coronary artery, which is likely to be affected by ischemic event. Okay. So, can you tell me which are all the leads you will look for to see whether there is a occlusion in the right coronary, and which are all the leads which you will use to detect the occlusion in the left coronary?
Right coronary, 2-3
AVF.
AVF.
Very good. Left coronary,
Left
depending
coronary.
upon
Left coronary.
depending upon the site. Whether it is septal, whether it is anterior wall, whether it is lateral or anterolateral. Okay. So these are all the common areas that we see. So right coronary, you look for leads 2, 3 and AVF. Fantastic, correct answer. For left coronary occlusion, the leads you have to look are lead 1, AVL, V1 to V6. Because this one is a major supplier for all the septum and the anterior wall. So remember these 3 leads for right coronary, and there are 6 plus 7 and 8 leads for left coronary because this supplies a larger area. Okay, and this is the picture commonly seen. All the textbooks are available. So for inferior, you can see 2, 3 and AVF demarcated. This is the right coronary supply area. And if you want to find out the lateral ischemia, you have to go for lead 1 and AVL. And septal branches are lead V1 and V2. Anterior branches are 3 and 4. And lateral branches are V5 and V6. So AVR is the only lead which does not have much of a significance. Other than that, all the 8 plus 3, 11 leads have got significance. Okay, if you remember that, you can easily diagnose. You don't require a cardiologist in emergency. You can easily make a diagnosis, and depending upon the ST elevation or ST depression, this is the classical ST elevation occurring in this is the depression occurring. So this is the picture. If you find, you can easily diagnose that. And Again, this is another picture of how to diagnose the septal, anterior septal, lateral, etc. And please remember this point, because sometimes they give an ECG in the exam and ask you to interpret. They will give only the simple, straightforward cases like the right coronary or left coronary occlusion, and so at least the basic thing you should be able to identify. Okay? Now, what are the EKG signs of acute coronary syndrome? Earlier in the picture, we saw how to locate right coronary or left coronary occlusion. Now, what will be the nature of the ST segment and T waves in EKG? That is the meaning of this EKG signs of acute coronary syndrome. Will it be ST depression or ST elevation or T wave inversion initially, or any other extra findings commonly?
ST elevation more than 1 millimeter.
It can
With
be ST elevation or ST depression. Mostly elevation includes ischemia, depression includes infarction. Okay, that is the common thinking. ST elevation occurs usually during early ischemic change, and depression occurs once the area has become infarcted. And if there is an ST depression, you should always look for pathological Q wave. Okay?
Q wave.
Q also will happen. So this is the normal. You can see P, Q, R, ST. Then ST segment elevation shows acute injury. So this is the acute J point. ST inversion is ischemia and ST elevation is injury. So this is the ST wave inversion, and the pathological Q wave will happen if there is a infarction already occurring, necrosis. So these three changes, remember, ST elevation, ST depression or T wave inversion and Q wave formation are all the indicators of acute coronary syndrome in a patient complaining with chest pain. So this is again another classical, you can see the ST depression in both 1, 2, and all these V4, V5, V6, all these things. So this interpretation of EKG may be given like this. So this is a main left coronary occlusion because the lead 1 is there, AVL is there, and V1 to V6, as we saw in the earlier picture, all of them are affected. So you find T wave inversion in 1 and AVL, which is a high lateral indicator, and ST elevation in V2, V1 to V2, which is septal, you can see that, and you have T wave inversion in V3 to V6, which is anterior. Okay? So these are all the findings that you see in this. Now, coming to the conduction system of the heart, what is the conduction system of the heart? Where does it start and how does it end? All of us know this right from our physiology days.
It starts from the
From SA node.
SA node goes to
AV node.
AV node. Before that, how is the atria supplied or are we stimulated? There are branches going from AV node to the atria, isn't it? Then only the atrium can contract. What are all the fibers that are the so-called bundles which supply the atrium? Okay. Prominently, you can say SA node, AV bundle of this left and right branches, and subendocardial Purkinje fibers. Okay? These are the 5 important components. But before going from SA node to AV node, it also supplies the atria. Okay? So the sinoatrial node, which is called the pacemaker, generates 70 to 80 impulses per minute, and then it goes through the right and left atria, it supplies, and then it stimulates the AV node also. And the AV node, after traversing in the upper part of the septum, immediately divides into right and left branches of this, and then finally ends up at Purkinje fibers. So, describe the anatomy of the SA node. what type of cell it is made of? Is it like a regular myocardial cell or is it a different specialized cell?
It can generate pacemaker potentials on its own.
Potential, action potential is slightly different, but it is a small horseshoe-shaped mass having a specialized myocardial fiber situated in the wall of the right atrium. As you can see, this is the right atrium. So it is almost close to the superior vena cava inflow opening. Okay, so that is where it is situated, and it's in the upper part of the sulcus terminalis, just before the opening, below the opening of a superior vena cava. And it is called pacemaker since it generates the impulses and it initiates the contraction of cardiac muscles. Both atria and ventricle contraction is initiated by the SA node only. What is the AV node anatomy? Where is it situated? From this picture itself, you can see that. Is it also present in the
Interventriculars.
It is very close to the interventricular system. Okay, it is a smaller compared to SA node, located again in the right atrium only, near the junction of the interventricular system, near the opening of the coronary sinus. So when you try to cannulate the coronary sinus for applying the cardioplegic solution, one has to be very careful. You can damage this interventricular septum. I mean the AV node. So it conducts the cardiac impulses to the ventricle by the atrioventricular bundle of His. Okay, so this is the connecting link between SA node, and this is situated also in the right atrium. And the importance of this anatomy is when you repair a venous ventricular septal defect in tetralogy of Fallot or in a simple straightforward congenital ventricular septal defect, there are chances that you may damage this node or the bundle of His that is arising from here, because the hole will be here, and one of the post operative complications of VSD closure is you may produce a heart block. Action fibers will get caught in the sutures and further transmission of the electrical impulses will not have occur. So that is why we have to know the. Similarly, when you do a ASD closure, you can damage the SA node also. If it is trying to put a patch or trying to do a closure, there is a possibility that you can damage these fibers going to the atria, and that is the importance of this anatomy. Now, how and why there is a delay in conduction at AV node? Normally, there is a spontaneous depolarization at the SA node, which travels to the atria and then come to the AV node and then go to the bundle of His to stimulate the ventricles. And you find there is a small delay. The electrical impulse does not travel like a jiffy from atria to ventricle. There is always a delay. And how do you find the delay? Where do you find the delay in the EKG? You trace the electrical activity of the heart.
PR intervals.
PR interval is the duration of the transmission. Okay, but so after the electrical impulses spread across the atria, they converge at the AV node. The AV node acts to delay the impulses by approximately 120 milliseconds to ensure that the atria synchronously contract. Because if there is no delay, what will happen? Atria and ventricle will both contract simultaneously. Then blood cannot be delivered from the atria to the ventricle. See how beautifully nature has timed it. So that is the reason for the small delay, that once the atria contract, blood should be emptied into the ventricle. Then the atria should relax and ventricle should contract. So to make this synchronous contractions, that is the reason for the delay at the AV node. Okay, so the wave of excitation then passes from the atrioventricular node into the atrioventricular bundle to stimulate that. So this is how this is the Bachmann bundle which goes to the atria, and this is a His bundle which starts here. And how this delay occurs? What is the mechanism under which this delay is produced in nature? Before the electrical impulses reach the AV node, we saw there is a small delay, so that atria will contract first, and then there will be a delay. By the time blood will be pumped into the relaxed ventricles which are not stimulated, then the bundle of fish starts stimulating the ventricles to pump the blood out. Okay, so what tissue prevents the conduction at the time? So this we saw as a, is there a difference between PR segment and PR interval? You answered that the importance of AV conduction delay is by PR interval. It is actually not the correct terminology to be used. PR interval indicates the travel time between the SA node to the AV node. But PR segment is the flat line between the end of P wave and the start of the QRS complex. And the PR segment reflects the time delay between the atrial and ventricular activation. Okay. So the PR segment also serves as the baseline reference for isoelectric line of the ECG. So this is the picture. If you see, this is the P wave which is starting here, and before it produces a small Q and then R wave, that is the QRS complex. This segment, this flat line that is happening between the end of P wave and the beginning of Q wave, that is called PR segment. But PR interval is actually the beginning of P wave to the beginning of Q wave. That is called PR interval. So end of P wave to beginning of Q is called the PR segment, and that reflects the isoelectric, the delay time of the at the atrioventricular node, which helps in the coordination between the atrial contraction and ventricular contraction. And the PR segment also gives the flat line to produce the basal isoelectric line. So only based on this, you say any segment is depressed or elevated, and that is also used by the same ST segment, which is a gap between the end of S wave and the beginning of P wave. And the ST interval is the entire time between the end of S wave to the end of P wave. That is ST interval, and this is ST segment. So these 2 points are very important for us to know whether the deflections are normal or abnormal. Now coming to the branch of the bundle of fish, it divides into right and left branches, and we commonly see these changes occurring or being reported in the ECG, right bundle branch block and left bundle branch block. What is the significance? Is right bundle branch block more innocuous, serious, or left bundle branch block is more serious?
Bundle branch.
Left bundle, any adjective to be added to that?
Complete
Recent
left
onset left bundle branch block. Okay, a recent onset left bundle branch block, which was not there earlier. If you compare the patients coming with chest pain, mild chest pain, and you find the evidence of left bundle branch block, and that same person has had an ECG done 3 months ago for some routine medical checkup, and you find that ECG was normal, then this left bundle branch block is called as recent onset left bundle branch block, which is an indicator of myocardial ischemia. Whereas right bundle branch block, majority of the time it is innocuous, can be physiological or as a result of damage to right bundle branch caused by causes like underlying COPD, congenital heart diseases like ASD, ischemic heart diseases, primary degeneration. These are some of the conditions, but this is very rare. Usually, a right bundle branch block is considered a normal variation or a physiological variation of the bundle of fish, and not much of significance will be given to that. Whereas left bundle branch block is always pathological, and left bundle branch block may be due to conduction system degeneration or myocardial pathologies like ischemic heart disease or cardiomyopathy or valvular heart disease. Okay, so they may give you the ECGs of right bundle branch block and the left bundle branch block. I have not gone into the details because we are mainly concentrating on the anatomy. That we will see later in our class on ECG, how to interpret the ECGs. At that time we will learn about that. Now coming to the innervation of the heart. How is the innervation happens in the heart?
Sympathetic area and parasympathetic.
It is mainly controlled by autonomic nervous system. So you have branches from both the parasympathetic and parasympathetic contribute to the formation of what is called cardiac plexus. Okay, this plexus consists of a superficial part, which is located inferior to the aortic arch, between the aortic arch and the pulmonary trunk, and then there is a deep part which is between the aortic arch and the tracheal bifurcation. Okay, so this location of the superficial cardiac plexus and deep cardiac plexus are very important when you do a tracheal surgery or aortic arch repair, aortic aneurysm repair. During that time, the surgeon has to be very careful with these cardiac plexuses which are controlling the heart. Now, what is the blood supply to the conducting system? SA node, AV node, bundle of
By
his.
right coronaries.
Mainly by right coronary. Okay, the whole of conducting system is provided by right coronary artery, with the exception of a part of left branch of AV bundle that may be by left coronary artery. Fantastic, very good. Describe the features of Purkinje fibers. Right, Purkinje fibers are subendocardial conducting cells, which are a network of cells. They are abundant with glycogen and have extensive gap junctions. These cells are located in the subendocardial surface of the ventricular walls and able to rapidly transmit cardiac action potentials from the atrioventricular bundle to the myocardium of the ventricles. Okay. So they are located subendocardially. What is the need for an artificial pacemaker? A clinical application. Which are the conditions where a pacemaker has to be implanted into the patient?
Very hard, third-degree heart block.
It may be because of the either a SA node defect or a conduction system defect. Okay, so artificial pacemaker is a small electrical device fitted to the monitor. May be common indicator to make a bradycardia. Usually, patients who suffer from bradycardia only we need a pacemaker to be inserted, and it can be sometimes used for controlling tachycardias also, and certain types of heart block and rhythm abnormalities require a pacemaker. Okay, sick sinus syndrome is one of the important conditions which require a pacemaker because the SA node, which is the normal pacemaker or physiological pacemaker, is not able to do its job properly. What are the properties of a cardiac muscle? Does it differ from your regular smooth muscles and the skeletal muscles? All your basic physiology.
It has intercalated cells and tight junctions.
What is that arrangement called? Several cells being interconnected with each other.
Palisading.
Syncytial arrangement. Syncytium. Okay. So the property is one is rhythmicity, automaticity, and chronotropism. Second is excitability, which is called bathmotropism. So these are all the terminologies used with the property of the cardiac muscle. One is it automatically contracts. So it has a rhythmicity, automaticity, and rate chronotropism. Then excitability is called bathmotropism. So the ability of cardiac muscle to respond to adequate stimuli by generating an action potential, and contractility, inotropism. And conductivity is called dromotropism. So these four terminologies, chronotropism, bathmotropism, which is excitability, and inotropism, which is contractility, and dromotropism. All of us are very familiar with chronotropic and inotropic activity. But this bathmotropism and dromotropism, ability of the cardiac muscle to conduct and get excited, is not commonly used. And there is a fifth tropism. What is that?
Lucitropy.
Lucidtropism, very good. When it is able to contract, it should be able to relax also. Okay, the diastolic function is also very important. So the fifth property actually should have been included is lucidtropism, its ability to relax to its original state. Sometimes we get a echo report saying that there is a diastolic dysfunction, grade 1, grade 2, grade 3. That happens because the muscle is not able to relax to its normal original level. So that is the lucidtropism. So remember these 5 tropisms, which are the properties of the cardiac muscle. And what is depicted in this picture? This is a part of the heart muscle which they have enlarged. And you can see the nuclei here. It is not an individual cell bound by that, and you can see they are all interconnected. So this is the peculiarity about the cardiac muscle. And this is what is called the syncytial arrangement of cardiac myocytes. Okay, the cell walls communicating with each other, and they have the tight junctions and all that. So a stimulus applied here will pass on to the entire thing. Unlike your skeletal muscles, which individual muscle fiber has to contract, produce a contraction. But here, a small stimulus applied to one part of the muscle will be entirely spread to other muscles. So there will be a coordinated contraction of all the things. And how they contract? See, the next question is describe the cardiac skeleton and contraction. So this is how the atrial musculature is present, and this is the ventricular musculature. So you can see there is a squeezing action, just like how you try to squeeze the water out of a cloth. So it twists like that, these two directions. The atria contract in this direction to empty the blood into the ventricle, and the ventricles go in a twisting action to empty their content into the aorta and pulmonary vessels. Okay? So this direction of arrows will show you their mechanism. And this is the other picture to show how the cardiac muscles of the two ventricles are located. And you can see the right ventricle is almost like a parallel arrangement, whereas left ventricle is the one which goes into this sort of squeezing action to produce the cardiac output. What is the contractile cell of the heart?
Myocardium.
Myocyte. Okay, it is the fundamental contractile is the cardiac myocyte. And it's composed of thick and thin interdigitating filaments called myosin and actin, and also tropomyosin, thin, and troponin complex. Okay, so these are the things, interdigitating things are present. And you can see this is a sarcomere, which is a myofibril component. Now, how is the contraction caused of this actin myosin complex? How is it caused? Which electrolyte or which element is very important for the contraction to occur?
Calcium.
Calcium, excellent. Cyclic decreasing intracellular calcium initiated by depolarization of the sarcolemma causes calcium release and reuptake by sarcoplasmic reticulum. That is, calcium will come out from the sarcoplasmic reticulum to initiate the contraction. Then it will go back into storage into the sarcoplasmic. So that goes into contraction relaxation cycles of cardiomyocytes. And this has to take place automatically. It is not under our will and command. So this is a automaticity of the cardiac myocyte which regulates that. So how is the cytosolic calcium regulated? We see that it is released from the sarcolemma or the sarcoplastic reticulum, and then reuptake takes place. So calcium comes out, goes into the cytoplasm frequently. But what regulates the calcium uptake?
Sarca, sir.
Sodium calcium exchanger.
Proteins in the sarcolemma called the cytosolic, which regulate that, and which components of the sarcolemma are involved in the contraction relaxation. That again is the thin actin filaments and thick myosin filaments. Okay, the thick filament is in the middle, and the thin filament is in the outer place, and they form a single unit called sarcomere. Okay? And in the relaxed state, you can see they are all quite away. And in the contracted state, what happens? The thin fiber come close to each other on either side. So it will contract the middle thick fiber also. And how exactly it is like our collapsing shutters which we have in our lifts or our houses. In the same way, it also collapses. And what is the role of ATP in this contraction? What happens if ATP production stops? Adenosine triphosphate. This is the power store or power energy bar of us. Okay. So this ATP is the one which there is a small myosin head from the thick filament. This is the thick myosin in the middle, and this myosin has got something like a hook which is attached to or very close to the thin filament. Okay? So this hook gets attached to the thin filament, and that attachment is done by the ATP, energy given by the ATP. I'm sorry, the attachment happens to produce the contraction. And after that, the normal aerobic respiration, the ATP which attached to the hook to produce this contraction gets released to the myosin to cause the detachment also. So it has to pull back the hook to cause the relaxation. So when death occurs and there is no oxygenation, the ATP production stops and the muscle goes into a rigid state called rigor mortis, because the ATP is not there to detach the hook which has got attached to the thing, and so the whole thing becomes contracted and rigid. It stands in the contracted rigid position. That is why the body becomes, it happens not only in cardiac muscle but the entire muscle. That is why in rigor mortis our muscles become so stiff and the body becomes very stiff, and we estimate the time of death by the appearance of rigor mortis, and that is because of the lack of ATP failing to release this contraction which has occurred to go to the relaxed state. Understand that? Right. Describe the anatomy of the, so we have so far seen something about the location, the supply of coronary vessels. Now the valvular importance. Commonly we get cases of mitral valve stenosis coming for either with pregnancy or for incidental surgeries. And so all of us have to know all about the mitral valve pathologies. For that, first we should know what is the normal anatomy of the mitral valve. What are all the components of mitral valve apparatus?
So mitral valve leaflets, anterior and posterior, chordae, tendineae, papillary muscles, and annulus of the mitral.
Annulus, four things, excellent. So this picture will show you, you have two leaflets. Mitral valve is the only valve which has got two leaflets. All the other valves are three leaflet valves or tricuspid valves. Mitral is the only one with a bicuspid valve. Sometimes anatomically or congenitally, you can have a congenital bicuspid valve in the aorta, which will cause aortic problem, stenosis problem. Whereas the natural formation is mitral is the only valve with two cusps. Which is the bigger cusp, anterior or posterior?
Posterior, here, mitral valve.
Mitral valve. I'm showing the picture of
Mitral valve, anterior valve is
anterior is
leaflet
bigger.
is bigger.
Okay, there's a thin posterior cusp or leaflet. Okay, so there is a thinner leaflet, there's a bigger anterior leaflet, and this is supported by a framework called annulus. Okay, and these cusps or valve leaflets are attached by the anterior chorda tendineae, and the chorda tendineae are arising from the papillary muscles, which are nothing but projection from the left ventricular wall and the right ventricular wall. Okay, so the same tendineae and the projections are there in both in the tricuspid as well as in the mitral valves, and the chorda tendineae are something to pull the valve downwards to open so that blood will flow from the left atrium to left ventricle and right atrium to right ventricle. Now, what is this? So, the mitral valve apparatus consists of mitral annulus. This is the supporting ring-like structure to which the two mitral valve leaflets, a bigger anterior and a smaller posterior, are attached. And this caudate tendineae are fibers to pull them down, which are attached arising from papillary muscles. Now, the histology of mitral valve and its importance. If you look at the microscopic picture, what are all the components of this valve apparatus, or rather the valve cusps? How many layers are there histologically? Any idea? Right. Again, you can see the beauty of nature. The mitral valve leaflet tissue is a trilaminar structure. There are three layers consisting of what is called fibrosa or ventricularis, which is on the ventricular side. See, the valve leaflet has got an atrial side, which is facing the left atrium. There is a ventricular side, the bottom portion attached with the caudate tendineae on the ventricular side. So the same valve has got a superior or inferior or a atrial and ventricular surfaces. And the ventricular surface, where is the pressure higher, atrium or ventricle?
Ventricle.
Ventricles. So this undersurface of the cusps are exposed to higher pressures. So to withstand that, you have a stronger ventricularis fibers. Then there is a spongiosa, which is at the very tip of the valves, where the two cusps are meeting. It is called the commissure. There you have something like a spongiosa or a soft portion, and there is an atrialis layer. So because the ventricular surface is exposed to higher ventricular pressures, it has got a dense collagen histologically for mechanical stability. On the contrary, the spongiosa is less organized collagen, which occurs at the leaflet tip of the rough zone, and it's rich in water and absorbent protein. This is mainly to give a tight seal whenever the atria is trying to fill up during diastole. It should not open out and leak immediately. So that produces a tight leak both during ventricular contraction as well as during atrial filling. So that is provided by the spongious layer of the valve cusp edges. And the atrial surface contains a network of collagen and elastin, which plays a critical role in leaflet remodeling and adaptation. Whenever the atria contract and ventricle contract, this is the surface which is adapting itself to keep the volume and the shape of the atria and ventricle. So there are three layers: fibrous layer with a strong dense collagen, spongy layer with the water and absorbent proteins, and atrial surface layer with both collagen and elastin for remodeling or the adaptation. What is the current preferred treatment for aortic stenosis in high-risk patients? Instead of talking about aortic valve, which is a bicuspid valve and has a more or less the same principle, except that there are no caudate tendineae, there are no papillary muscles attached to the aortic valve. So, what is the current preferred treatment for aortic stenosis?
TAVI, sir.
Very good, excellent. TAVI, which is called TAVR, replacement or implant, is an established technique for treatment of patients with aortic. So it is being done in the cath lab transarterially through the femoral artery, and the entire valve is repositioned in aortic stenosis in high-risk patients, and this is gaining more popularity, and open surgery is now coming down in number because of the ease with which it is done. What is the one most important complication of this procedure, which can happen immediately on the table or a little later?
Rupture or bleeding.
See, the valve is placed very close to the bundle of fish. That is the clue. So if the valve is going to press on the bundle of fish and block the conduction, what can happen? patient
Low
can
cardiac.
develop heart block. Heart block. Okay. So one of the common complications of this procedure is heart block, and patient may need a emergency or immediate pacemaker placement. That is the major, most common complication of this. Now, this is become almost a routine procedure now, but a replacement of mitral valve in the same transcatheter approach is not very popular. Why?
Mitral
Looking
valve
at
contains
this
more fibrous tissues.
more complex. Okay, it is not a simple bicuspid valve like tricuspid valve, which is not having any cardiac tendon or papillary muscle attachment. So you can just put it in the same annulus of the aortic valve very easily. Whereas here you have to remove or damage all these things. So the complex nature of the mitral valve anatomy makes it difficult, more challenging, and anchoring is one of the main problems due to asymmetry of the mitral valve annulus. So because you have a larger anterior cuff and a smaller posterior leaflet, the annulus also differs. So fixing the valve in this position would be more difficult by transcatheter route. That is the reason why it is not more popular. Now we are going to the physiology of cardiac cycle. What is a cardiac cycle? So in the anatomy, to recap, we have to know the anatomy of coronary vessels, the venous drainage, and it's important about coronary sinus and cardioplegia. Then we have to know about the blood supply to the various conducting systems. Then we have to know something about the valvular apparatus. Now we are switching over to the physiology of cardiovascular basics. What is the cardiac cycle? The chain of events, isn't it? Cycle means there's something going again and again. So systole, diastole, in between that, the 4 stages. Okay, is defined as the succession of coordinated events taking place in the heart during each heartbeat. So it consists of 2 major portions, systole and diastole. So during systole, the heart contracts, all basic things. Diastole relaxes and blood receives. So that is this happens in a cyclic manner, which is called the cardiac cycle. Okay? What is the duration of the components of each one, systole and diastole?
Systole is 0.3 seconds, diastole is 0.8, 0.5 seconds.
Okay, so based on that the cardiac cycle only your heart rate happens, or during the heart rate the components have different timings. So when the heart beats at a normal rate of 72 beats per minute, each cardiac cycle has a duration of 0.8 seconds. Of that, the atrial event, the systole is 0.11 or 0.1 second, and atrial diastole is the rest, 0.67. And the ventricular is systole is 0.27, slightly larger, and ventricular diastole is 0.53. Okay? So in clinical terms, systole, ventricular systole, diastole is ventricular diastole. We don't talk about the right ventricular systole and diastole mostly because this is the most important thing for supply of blood to the entire body. Whereas right ventricular output is only mainly to oxygenate, which goes into the pulmonary circulation. So whenever we say a systole, we always take into consideration the ventricular systole and ventricular diastole. So the ventricular systole also has got subdivisions. It has an isovolumetric contraction phase, which is 0.5, rapid ejection phase, which is 10 seconds, and slow ejection phase. So roughly it is about 0.3 as we said here. So 15 plus 10, 25 plus 5, 30. So 0.3 seconds is the ventricular systole, and the rest 0.5 will be the ventricular diastole, where it is divided into isovolumetric relaxation, rapid filling, slow filling, and filling due to atrial systole or atrial kick. That is somehow it's called. So each one has got its own duration. So this duration will be adhered to in normal heart rate of 72. But when the heart rate varies, tachycardia happens, which one will get affected more? The diastolic filling time will be affected more. Okay, so that is the importance of atrial. What is the importance of atrial contraction or atrial systole? Is it important in physiological normal heart, or it is important in
In
pathological
elderly,
condition?
sir. In elderly, they depend on the atrial,
Elderly,
and
okay.
it is lost in atrial fibrillation. So
It is more important in failing hearts, okay, because atria contribute only to a smaller percentage of the left ventricular filling. So atrial systole is also known as the last rapid filling phase or pre-systole phase. It is usually considered as the last phase of ventricular diastole, and the duration is 0.11. During this period, only a small volume of 10% of blood is forced into from the atria into the ventricles. So normal physiology, this does not carry much of a importance. Whereas if the heart is failing, then atrial contraction becomes a major contributor to the left ventricular filling, and that is the time it becomes very important. And describe the various stages of cardiac cycle. This is again atrial diastole starts after atrial systole. Simultaneously, ventricular systole also starts. Okay, these are all the things mostly repetition. But these terminologies we should know. One is isovolumetric contraction period, the ejection period, protodiastole, isometric relaxation. These are all ventricular events. Rapid filling, slow filling, and last rapid filling phase. And each one has got its own timing. And the first heart sound is produced by the closure of AV valve. Very, very basic thing. And the ejection period is important because due to the opening of semilunar valves, isotonic contraction of the ventricle, blood is ejected from out of the both ventricles. And this period is called the ejection period. It occurs in two stages. First stage is rapid ejection phase. When blood is pumped out of the ventricle, the initial force produces a rapid delivery. So first stage, immediately after opening of the aortic and the pulmonary valves, the blood is forced into the aorta and the pulmonary artery. This stage, a large amount of blood is rapidly ejected from both ventricles, and the duration of this is 0.12. Now the second phase will be a slow ejection phase. During this stage, blood is ejected slowly with much less force, and this duration is 0.09. And there is a pre-diastole period. This is the first stage of ventricular diastole. Proto means prior to diastole. Prior to the full relaxation, there is a smaller period, and this is 0.04 seconds. During the ejection of blood, the pressure in the aorta and pulmonary artery increases, and the pressure in the ventricle will decrease. And during this period, when the pressure becomes less, the pressure increases in the semilunar arteries, and that forces the closure of the semilunar valves. So that produces the second heart sound. So all these basics all of you know. Then there is an isometric relaxation period. Then there is a rapid filling of the ventricles from the atria without any contraction of the atria by the increase in the pressure in the two chambers. And there is a slow filling once the pressure becomes equal between the two chambers. And lastly, there will be the contraction of the atria. So all these things I will just skip through. And this is the graphical representation, how the whole thing happens and why the dicrotic notch happens, and the left ventricular pressure and atrial pressures are happening. Now there is one important concept which you have to understand, is what is called the Wind-Kessel effect. All of you heard about this terminology? Wind-Kessel effect.
In blood vessel arteries.
Which artery? Not a blanket all arteries. It is mainly an effect. Aorta, especially after the blood is pumped from the left ventricle into the aorta, because the aorta is elastic, it is actually responsible for a compressive effect that converts the basic systolic inflow produced by the ventricular ejection into a smooth and more continuous outflow of the peripheral vessels. So this picture will help tell you how to understand this Wind-Kessel effect. So the left ventricle is pumping the blood, a large quantum of blood into the aorta. So what happens in the aorta, because it is quite elastic, it stretches out. So this dotted line is the normal size of the aorta. It stretches out, and then the blood immediately, the pressure drops a little bit. And then what happens when the flow stops because of the closure of the valve? The stretching of the aorta recoils and comes back to its normal level. That helps to push the blood further. Okay, otherwise what will happen, in one shot the blood will try to go and it may not reach the entire periphery. So nature is so beautifully done, it retains a portion of the blood in this portion, and then recoil pushes the flow, so there is a continuous flow. Otherwise, after one contraction, there will be some flow, and during diastole, there will be no flow at all. So once the valve closes also, the circulation has to go on. So this Wien-Kessel effect is very, very important to have a continuous flow of blood, because the aorta retains a part of the flow by stretching, and once the valve closes and the pressure drops, it comes back to its original position to push the blood further, so there is a continuous flow. The volume of blood is displaced by the recoil, furnishes a continuous capillary flow through diastole also. Otherwise, what will happen, only during systole you will have some blood supply, and during diastole there will be no blood supply. So in order to avoid that problem, this Wien-Kessel effect helps in pushing the blood both during active systole as well as during diastole. Can you imagine a similar arrangement in our respiratory system, where during inspiration you are able to take the oxygen? What will happen during expiration? The air is going out of the body to eliminate the carbon dioxide. So how does the body tissues get oxygen during that time, during the expiratory phase of respiration?
FRC.
FRC, fantastic. The same concept applies to this also. Okay, in order to get a continuous blood oxygenation, your FRC is there, functional residual capacity. You can imagine this is more or less the same concept. There is a collection or the retainment of some blood in this stretch aorta. When this function can be affected? Aorta is normally elastic.
Atherosclerosis.
Atherosclerosis. When it becomes stiff, this action cannot be happening, and that is the reason why it gets affected. So the factors responsible for this is the elasticity of the aorta. Second is presence of peripheral resistance, and third is proper function of the aortic valve. All these three are very, very important for this Wien-Kessel effect. Okay. So what are the effects of atherosclerosis on this Wien-Kessel effect? Elasticity will be lost, peripheral resistance will increase more, and function of the aortic valve also may be affected. So what will it result in? When the stretching is not there and the resistance is more, what will the left ventricle has to do to overcome that?
Hypertrophy.
Pump more. That is why you develop hypertrophy and all that. Okay, so this is how the whole problem can happen. So there is increased pulse pressure. Diastolic pressure becomes low, systolic has to increase, decreased diastolic perfusion, and increase in cardiac workload. Okay, so all these things happen because of the flow, and this is about Wien-Kessel effect, which all of us have to know. Okay. Now coming to another important concept, which is a gray area to most of us. What is mean arterial pressure? What factors determine the mean arterial pressure?
Diastolic pressure plus 1/3 of pulse pressure is
That is how you calculate the value of mean arterial pressure.
the average of systolic and diastolic.
So the definition of mean arterial pressure is the average arterial pressure through one cardiac cycle of systole and diastole. Okay, that is the definition actually. And MAP is influenced by both cardiac output and SVR. So cardiac output determines which pressure? Systolic or diastolic? Systolic. SVR determines diastolic.
Diastolic.
So both these things will affect the mean arterial pressure. Okay, so this is an average of arterial pressure both during cardiac and systolic and diastolic. And so because systolic is dependent on cardiac output and diastolic is dependent on SVR, mean arterial pressure is dependent on both, and that is why it is called a mean average arterial pressure. And the calculation is diastolic pressure plus 1/3 of the pulse pressure, which is the difference between systolic pressure and diastolic pressure. Okay, so this is the normal pulse curvature where you get the so examiners may ask you by showing a normal plethysmographic tracing and ask you to identify how to calculate the mean arterial pressure. So here the bottom portion is the diastolic and the peak of the curve is the systolic. So in between the two, the normal calculation like this, you have to mark it at 93 if they give you the values, so that you can manage calculate the mean arterial pressure in this. Now, what is pulse pressure and what is its importance?
Difference between systolic and diastolic blood pressure.
Diastolic is pulse pressure. Very good. What is the importance? A widened pulse pressure occurs in several diseases like aortic regurgitation, aortic sclerosis, severe iron deficiency anemia, arteriosclerosis, hyperthyroidism. Okay, so narrow pulse pressure occurs in diseases like heart failure, blood loss or hypovolemia, aortic stenosis, cardiac tamponade. And in majority of these cases, systolic pressure decreases while diastolic pressure remains normal, and that is the reason why the pulse pressure becomes quite narrow. So the pulse pressure is significant risk factor for the development of heart disease. And pulse pressure is independently associated with an increased risk of developing atrial fibrillation also. And narrowed pulse pressure is seen in dysautonomia or postural orthostatic tachycardia syndromes, where the systolic blood pressure drops and diastolic remains normal. So there is a narrowed pulse pressure, and this may produce what is called postural orthostatic tachyarrhythmias. So this is the clinical importance of the pulse pressure also. Now another common thing is jugular venous pulse. So the exams they may give you, especially OSCE, they may show the graph of a JVP. So this is the JVP tracing that you can, and questions can be asked. So what are the various phases or the deflections of a jugular venous pulse tracing?
ACB is positive, sir. X and Y is negative, sir.
Okay.
A is
What are
atrial,
the
A is atrial contraction. C is tricuspid bulge into the tricuspid.
Tricuspid valve projecting into the right atrium because of the right ventricular contraction. Okay. And V is the right ventricular contraction producing inside initiation. This is the early stage, that is the ventricular systole. Okay. So that is the indication for that. And D, X and Y are the inflow, fall in the, so A wave is due to atrial systole, causes increasing intra-atrial pressure. C wave occurs during isometric contraction of the ventricles due to bulging of the tricuspid valve. V wave is due to accumulation of blood during late part of ventricular systole or protodiastolic stage and isometric relaxation. That is the negative, positive wave. These three positive waves are happening. And these are also called X descent and Y descent due to downward displacement of the AV valve, and Y descent is due to opening of the AV valve during maximal ventricular filling phase. Okay, so these are all the things. And the AC interval measures the time of conduction of cardiac impulses from right atrium to ventricles. And the AC interval corresponds to the PR interval in the ECG. And the AC interval is prolonged in cases of delayed conductivity, as in AV bundle branch bundle, which is an early sign of heart block. And partial heart block, the number of A waves is greater than the number of C and V waves. and the atrial fibrillation, the A wave will be totally absent. So these are all the significance of this characteristic. And sometimes you can get a cannon wave. What is a cannon wave?
The large A waves.
Large A wave due to dysynchronous or asynchronous contraction, producing a very high pressure that happens in heart block. Okay, that is the reason why in the initial phases we saw that the AV conduction delay is very, very important. Okay, so this is the correlation between these various things that are happening, and this is depicted here, the various stages of cardiac conduction. So this can be gone through visually. Now comes another important concept of physiology, is the action potential of atrial and ventricular myocytes. How do they differ from each other? This is one of the common things we have to understand.
One has a plateau phase, the other doesn't have a plateau phase.
Okay, for remembering the action potential of, it can be non-pacemaker cardiomyocytes or pacemaker cells. Okay, so the instead of this wording, I should have produced pacemaker and non-pacemaker myocyte active action potential. So a non-pacemaker, how many phases are there in the action potential?
4 phases.
4 phases.
4 phases. Yet pacemaker
That's
action
the
potential, only 2 phases.
2
Okay?
phases.
So to remember this, you have to remember the mnemonic: summit, plummet, continue, plummet. Okay, these are the 4 terminologies that you have to remember. Summit, plummet means going down or falling down. Continue, again plummet. So we will see the first phase of that, which is called phase 0. This is for non-pacemaker cardiac myocytes I am describing. So when cardiac myocyte becomes stimulated by a current, the resting membrane potential, which is normally minus negative 90 millivolt, becomes more positive. That is, it becomes less negative, which is actually it will not become plus, but from minus 90 it will become minus 70, which is more positive, to generate a threshold. And once the threshold is achieved, the action potential will submit as the voltage across the cell membrane becomes more and more positive. It will become from minus 70 as to go to minus 40, minus 20, like that. It will become less and less negative. And this is referred to as depolarization of its phase 0 or action potential. And this word, yes, you have to remember that this is mainly because of the movement of the sodium. So to remember the first phase, it is caused by sodium in the ventricular non-pacemaker myocytes. And the sodium channels open when the threshold of the cell membrane is met, and the influx of sodium leads to depolarization. So phase 0, summit phase, is action potential by sodium influx. So this is the starting point of the action potential, phase 0, which reaches the summit, goes to the top. Now the second phase is potassium or plummet, which happens with the phase 1. And as the sodium influx occurs, the sodium channels, after some time, they have to close. Once they close, what happens? The potassium channels open and the potassium is being pumped out. The plummet starts, that is going down, happens, which is the potential plummets to where potassium is involved. So the sodium channels from phase 0 have closed, thereby reducing the influx of sodium, and potassium channels are open, leading to efflux of potassium ions, and slight repolarization of the cell starts. And so remember that phase 1 is by plummet phase of action potential and potassium going out of the cell, efflux. And this is how the second phase starts, atrial myocytes, the phase 1. And the third phase is due to calcium, where it continues, and you can just see this L-type calcium channels are open here, and the influx of calcium to replace the potassium that is gone causes a slight myocardial contraction. This leads to a slight systole. So the C continue is given to remember it is because of the calcium. So after the sodium causes a summit, by potassium go up, there is a plummet or a fall. Then there is a continuation or a plateau produced by calcium. And the last phase is phase 3, again caused by potassium. And this plummet is by the potassium going out, efflux. So sodium and calcium are coming inside the cell. Potassium extrusion are going out is the one to reproduce the repolarization. So you can see there are 4 phases. Even though this is called 0, this is the first phase. Phase 1, 2, 3, 4 phases are there in the normal atrial or ventricular myocyte. These are not stimulus producing or the pacemaker cells. Okay. Now coming to the resting phase, that is the almost you can say 5th phase, where it goes back to the plateau line. This is called the 4th phase. So in action potential, first phase is not called number 1 phase, it is called phase 0. Then the repolarization phase 1, then the plateau phase is phase 2, then the full repolarization is phase 3, and the baseline is the resting phase. So actually you can say there are 5 phases rather, including the 0. But when it comes to the pacemaker cells, there are specialized cells which conduct, and easy to remember because there are only 2 phases. The mnemonic to remember is climb and plummet. Instead of summit, why we have given climb is because to identify it is the calcium which is very important for the depolarization to happen. Whereas sodium is the main element for depolarization to happen in the regular myocyte. So calcium causes phase 0, spontaneous generation of action potential, and phase 0 climb action potential due to calcium effects, and the same picture but not due to sodium but due to calcium in SA node and AV node. And the second phase is actually the phase 1 and 2 are not there. That the mild repolarization and plateau phase are not there in the pacemaker cells. So phase 1 and phase 2 are not there. Cells do not need to contract. They only have to generate the impulse and pass it on. So there is no actual contraction needed. So that is the reason why phase 1 and phase 2 are not there. And SA node has the automaticity to generate its own depolarization and repolarization, and the AV node to conduct that. So the non-pacemaker cells cause repolarization by again efflux of potassium. So for repolarization, we have to have only the potassium to go out of the cell, which is mainly an intracellular element. And this is a simple upward arrow like curve that you have to draw for SA node. So phase 1 is by calcium depolarization. Phase 3, which is repolarization, is by potassium. And of course, this phase 4 will be baseline for anything. So the main 2 things are phase 0 and phase 3 for SA node. And if you compare the picture of both the things, atrial potentials of atrial myocyte and SA node, to have these 4 things and the simple phase 0 and phase 3 for SA node. So this is a very common concept that you have to remember very well, so that theory exams or in the practical viva, they may ask you all these things. So 3 elements are only important: sodium, potassium, and calcium. And calcium is main for SA node, pacemaker cells for depolarization. Whereas in the myocyte, it's mainly for the plateau phase. Whereas potassium is the universal efflux element for repolarization. And for active depolarization, for myocyte, it is sodium, and pacemaker cells, it is calcium. I hope it is quite clear now. So these are the various action potentials as they are drawn, and what are all the elements, again in another pictorial form. Now, what is the practical application? Why should we know about this action potential? Why break our head? Which element goes in, which element comes out, which element causes plateau, which element causes depolarization? What is the importance?
Antiarrhythmic drugs.
Antiarrhythmic drugs, very good. One reason.
Cardiac inotropes.
cardiac inotropes. Okay, to understand the basics of cardiac arrhythmia and the mode of action of drugs. Fantastic. These are the two important reasons for knowing that. So there are 4 different classes of antiarrhythmic drugs which we use. Can you name them?
Class
How do
1
you
sodium
classify
channel blockers.
antiarrhythmic drugs? Class
Sodium
1, class
channel
2,
Class
class
channel.
3, class 4. Class 1 is sometimes divided into
ABC,
A and B also.
ABC.
Okay. So the mode of action of these antiarrhythmic drugs
Sodium channel.
by first class is beta blockers. Okay. Sodium channel blockers. Second class is beta blockers. Third is potassium channel blockers, and fourth is calcium channel blockers. Okay. So this can be remembered by each class of medication functions by blocking different phases of cardiac myocyte and pacemaker cell action potential. That is the reason why we have to know about that. And the mnemonic to remember is these 4 classes is sodium blocks potassium channels. Because the class 1 drugs block the sodium channel. Class 2 drugs are beta blockers. So you remember the blocks. Class 3 are potassium channel blockers, and class 4 are calcium channel blockers. So you take the channel and block from the beta blocker, and sodium and potassium are the 2 elements. So you can easily remember the 4 groups. Sodium blocks potassium channels. So this channel blocks the calcium channel. This block is the beta blocker. Okay, so easy to remember that. What different conditions are produced by different pathology? Supposing you have a problem with the sodium channel or the calcium channel or potassium channel. What are the different pathologies that can be produced? Supposing you have some problem with the calcium element, which part of the conduction system will be affected? SA node or AV node? Pacemaker cells or cardiac myocytes? We saw the action potential of pacemaker mainly involves which element?
Cardiac myocytes.
Calcium. No, calcium is the main element for the depolarization of the pacemaker cells, isn't it? That's what I have been shouting all this time. Sodium is for cardiac myocyte. Okay, so problem with conduction of the heart can lead to heart block or dysrhythmias. Conduction disorders can affect SA node, 6 sinus syndrome, or AV node into first and second and third degree blocks, bundle of branches where it can produce right or left bundle branch block. They can also cause disorder of the ion channels, which produce what is called the long QT syndrome or Brugada syndrome. Okay? These are all the various pathologies that can be affected. What is the neural regulation of action potential? Already we saw the innervation is by
Parasympathetic.
autonomic nervous system, both sympathetic and parasympathetic. So, how does the neural regulation act? It is by autonomic nervous system influences. So, sympathetic, how does it act on the heart? Which receptors they will have to activate? Alpha beta receptors is the sympathetic system, beta adrenergic receptors, which increase heart rate and cardiac contractility by increasing the slope of phase 4 in pacemaker cells. We saw the pacemaker slope. Phase 4 is the baseline. Okay, the slope, if it is increased immediately, this depolarization will start, and augmenting the phase 2 in non-pacemaker cells. Okay? So that is phase 2 is the repolarization phase by the potassium efflux. Okay, so in phase 4 it increases the slope or the resting phase in SA node and AV node, whereas in the myocyte it augments the phase 2 of non-pacemaker cells. And parasympathetic activates the muscarinic cholinergic receptors to decrease the heart rate by slowing the heart rate and the rate of depolarization. So by slowing down the depolarization, the active stimulation is decreased by the parasympathetic nervous system. Now, this is one question that was asked in the theory exam. Describe the various cardiac reflexes, cardiovascular reflexes that are associated with the cardiovascular system.
Bainbridge reflex.
Very good.
Oculocardiac reflex, respiratory sinus
Ocular-
arrhythmia.
Very good.
um,
Okay.
Chemoreceptors, basal gyrus.
Oh, yeah. Basal gyrus. Very good. So the reflexes are baroreceptor. This is the first and foremost response you have to say, because this is the one which regulates the blood pressure. Okay, it is also called pressure receptor reflex. Then there is a chemoreceptor reflex. Then there is a Bainbridge atrial reflex, which is also called the volume reflex or atrial stretch reflex. There is a basal gyrus reflex, which is called the cardiopulmonary reflex. Then there is an oculocardiac reflex or trigeminal reflex. Then there is a Cushing's reflex and the reflex due to Valsalva maneuver. Okay, these are all the cardiovascular reflexes that we have to know. What is the importance of baroreceptor? There is also known as carotid sinus reflex or pressure receptor reflex.
When the heart rate or BP is falling, it will baroreceptor will activate to increase the heart rate and
Heart rate or BP is falling. Baro means pressure, isn't it? It also says pressure receptor. So where are they situated, first of all?
carotid sinus and aortic arch.
So when they sense there is a fall in the pressure because of hypovolemia or the heart rate, so reflex initiated by the stretch receptors called baroreceptors, which are present in the carotid sinus, aortic arch walls of right atrium, the entrance of SVC, IVC, and walls of left atria, and the entrance of pulmonary vein. So many locations these stretch receptors are present. And these receptors in low pressure part of circulation are called also cardiopulmonary receptors. They are stimulated by the distension of the structure in which they are located. So if the walls of these anatomical locations like carotid sinus, aortic arch, if they get stretched by the pressure induced, the pressure in these structures are associated with the discharge rate. So it will immediately cause a reflex reduction in the pressure. They have to, and if the pressure is low, it has to stimulate the heart to pump more to bring back the pressure to normal. Okay, higher the pressure, it has to reduce the flow. Lower the pressure, it has to augment the flow. So that is the main purpose of this baroreceptor reflex, and this is the mechanism how it is. See, these are the locations. This is the carotid arch, carotid sinus. This is the aortic arch location. So whenever the blood flow alters, and the blood flow is the important thing to cause the pressure. So if there is a high flow, the pressure will be more. So heart has to reduce its pumping and bring back the pressure to normal. If the volume pumped out is low, pressure will be low. So heart has to be stimulated to increase the pressure. And this is the main mechanism to keep our blood pressure under a constant value, which is the most important thing we have to remember. The next baroreceptor respond extremely to rapid changes in BP within fraction of seconds. So the importance of that is to keep the arterial pressure relatively constant, short-term regulation of blood pressure in the range of 70 to 150, and maintain the mean blood pressure at about 100 millimeters of mercury, and the pressure buffer system to reduce blood fluctuation during daily events such as changing the posture, respiration, or excitement. And baroreceptor resetting, when will it happen?
Chronic hypertension.
Hypertension, very good. It has a chronic term of blood pressure, will adapt to long-term change of blood pressure. So that if the blood pressure is elevated for a long time, as in chronic hypertension, the set point will transfer to the elevated mean blood pressure. That is why in chronic hypertensives, sudden reduction in blood pressure is very dangerous. It can produce, so these decreased baroreceptor response in patients with chronic hypertension will make the baroreceptor system unimportant for long-term regulation of arterial blood pressure. So calcium channel blockers, AC inhibitors, phosphodiesterase inhibitors, all of them decrease the cardiovascular response to increasing BP through this reflex. Whereas baroreceptors are compromised with diabetic neuropathy also. And volatile anesthetics, particularly halothane, inhibit the heart rate component of the reflex. that is the reflex tachycardia or bradycardia based on the blood pressure, will be affected by halothane and not much by the other agents. And these reflexes are well preserved with moderate doses of fentanyl, but high doses depress this reflex also. Okay, so these are all called the baroreceptor resetting. Now, coming to the next part of the receptors, the chemoreceptors. They have central and peripheral chemoreceptors which change. So the chemical change, which is the chemical which is going to alter or cause a response?
PCO2 and
PCO2, carbon dioxide. Central chemoreceptors respond to only to acidosis. Okay. So peripheral
Hypoxia.
chemoreceptors are sensitive to changes both in arterial and carbon dioxide tension and to the pH. Okay. So increasingly important when mean arterial pressure falls below 60 millimeter, when the arterial baroreceptor firing rate is at its minimum. Okay. That is how the whole thing happens. Then the main bridge atrial reflex. What is the role of this? This is more of a volume reflex. So what should the heart do when the volume is increased? What should the heart do when the volume is decreased? Should it beat more or
On
beat
the
less?
right atrium.
When the increased filling of right atrium, it will increase the heart rate.
Stretching of atrial stimulates stretch receptors present in the right atrial wall and cavo-atrial junction, and this will lead to vagal myelinated afferent fibers. Okay? This will lead to cardiovascular center activation of medulla. This will lead to different vagus nerve stimulation. Okay? That will lead to inhibit the parasympathetic activity, which will increase the heart rate. So the brain bridge reflex, when there is more volume, that stretches the pressure receptor, activates the center in the medulla, and acts out through the effective vagus, inhibit the parasympathetic activity, and heart rate will increase. And directly stimulates the SA node to increase the heart rate also. So the brain bridge reflex and the baroreceptor act antagonistically to control the heart rate. The baroreceptor acts to decrease the heart rate when blood pressure rises. Whereas when blood volume is increased, the brain bridge reflex is dominant. Blood volume is decreased and the baroreceptor is dominant. So blood volume increase, brain bridge will come into action. When the blood volume is diminished, baroreceptor will come into action. So these are two opposing reflexes which are helping the heart to maintain normal cardiac output. The next one is the Basal-Jarris reflex, which responds to noxious ventricular stimuli sensed by the chemoreceptors and mechanoreceptors. Both the receptors are involved in that. In the left ventricular wall, this is the sign of or the location of these receptors, and induce a triad of changes: hypotension, bradycardia, and coronary artery dilation. And the afferent for this is the unmyelinated C fibers, reflectively increase parasympathetic tone as it involves bradycardia, and the reflex is thought to be a cardioprotective reflex. And which conditions this will be caused is implicated in myocardial ischemia or infarction, during thrombolysis, revascularization, or in syncopal attacks. So this is the entire picture, how it, so reflex syncope, how it happens and how it is corrected. This you can see it later. This oculocardiac reflex is a common question asked during any splint surgery or any splint-based discussion. This is a very common thing which will happen. All of you are aware of that. It's also called the trigeminal-vagal reflex, and is known as also Ashner reflex. And it is mainly because of the pressure on the eyeball, and it decreases the heart rate more than 20% following global pressure or traction on the extraocular muscles. And the reflex commonly results in sinus bradycardia with a hypotension. Sometimes arrhythmias or asystole can also happen. The treatment, all of you know, is to stop the insulting pressure or the traction, and then immediately it will get reverted. If it does not come back to normal, we have to use atropine for increasing the heart rate. So this is commonly encountered during ophthalmic procedures like strabismus surgery, and also it can cause all these things. So all of that you know. So I'm not going into the details. The pathway afferent efferent trigeminal is the afferent and vagus is the efferent. That's why it's called trigeminovagal. If you remember that, you can write it in your notes. And the effects and the special characters, stick through that. And what are the ways of prevention? All that we have seen in our. Then coming to the Cushing's reflex. What is this Cushing's reflex? Any idea?
Due to raised ICP.
Ah, fantastic. As a pressure Cushing resection or Cushing phenomena, raised ICP produces the triad of symptoms like increasing systolic and decreasing diastolic, bradycardia, and irregular rhythm. So this is called the Cushing's triad. Okay? So the heart changes here are raise in systolic pressure and decrease in diastolic pressure, and heart rate also will go down. And it is proposed by Dr. Harvey Cushing, a neurosurgeon. Cushing triad is a late sign of ICP with a brainstem herniation is imminent. So if it happens in a head injury patient, this is very ominous. And these are all the things that happen. And Valsalva maneuver and heart post excitation against the prostalatis. When will you do the Valsalva? What is the importance of Valsalva maneuver? Which condition you have to do this?
Check for any.
To detect autonomic neuropathy. This is done to direct mainly autonomic neuropathy. So you can do that by asking the patient to blow through prostalatis. So it has got 4 phases: phase 1, phase 2, phase 3, which all of us have learned earlier. So these are all the transient rise in blood pressure followed by a fall in sweat volume. So these 4 things happen. The assessment of what? The microphone has to be switched off. What are the contraindications to perform Valsalva maneuver? Any idea? What are the contraindications to perform Valsalva? Coronary artery disease, valvular heart disease, or congenital diseases, and raised intracranial pressure or intraocular pressure. Those cases you should not do that. Okay? These are the changes that happen phase 1, phase 2 in the aortic pressure and the heart rate. This picture will easily tell you how it is happening. Now coming to the control of cardiac function, because we have already seen that, so I'll go through that faster. The SA node is a pacemaker which will stimulate when it goes through the conduction system. Role of autonomic nervous system, it controls the blood pressure, respiration, body temperature, everything. And ANS, however, is controlled by centers located in the spinal cord, brain, and hypothalamus. Which nerves of ANS has important cardiac function? So this is again the which location. T1 to T4 are called the cardiac accelerator fibers. This knowledge is important because when you give a spinal and the level goes very high up to the thoracic segments T1, T2, patient will develop severe bradycardia because of the cardiac accelerator fibers are mainly supplying from this, and these are the vagal connections. So what are the neurotransmitters and receptors involved in the ANS control of cardiac function?
Norepinephrine, dopamine. To cause bradycardia, parasympathetic transmitter, acetylcholine. Okay, so norepinephrine, acetylcholine. Dopamine is very not very commonly used in physiology, okay, but main
transmitter is norepinephrine and acetylcholine, which acts on the alpha 1, beta 1, and their various effects. Okay. Signal transduction of beta adrenergic and muscarinic receptors. They are mainly G protein coupled receptors. Okay, this is just to show the type of receptors that they are and the various categories. And the role of phospholamban in cardiac muscle contraction. This is one thing which mostly students may not be aware of that. Heard of this terminology, phospholamban? So this is a key regulator of cardiac contractility. It modulates the so-called sarcoplasmic calcium sequestration by inhibiting the sarcoplasmic calcium ATPase in the dephosphorylated state. Okay. So that is how the contractility and the relaxation are modulated. So when I told you that the importance of ATP in the last picture I showed on the contraction, coupling, and relaxation sequence, the phosphorylation, which is mediated through beta adrenergic stimulation, the inhibitory effect of phospholamban on the function of CRT is relieved, so that the calcium will be reuptake will be happening in the sarcoplasmic reticulum to terminate the contraction. Now, what are the types of calcium channels and their properties?
L type, T type, and N type.
Only two types?
Three types, L, T, and N type.
Where are they located?
L type in cardiac.
Any muscle contraction, you need that. So L is because of long lasting. That is the reason for the L. T is for transient current, and N is mainly in the neuronal. So they are all voltage sensitive calcium channels, and their conductance is about varying 25 PS and 8 PS and 12 to 20 PS. Activation threshold is quite high activated L type, low N type is also highly activated. Inactivation rate is very slow in L type, much faster in T type because it's a transient current and it is medium. And their location are in the excitation, contraction, coupling in cardiac and smooth muscle. You have the L type, and SA node, AV node conductivity also you have L type. Endocrine cells for hormone release you have L type, and neuronal transmitter release also you have L type. Whereas P type is present to some extent in SA node pacemaker activity, T current and repetitive spikes in thalamic and other neurons, endocrine cells for hormone cells, and certain arteries for constriction. And N type is mainly present only on neurons in the CNS and sympathetic and myenteric plexus. And drugs which can block the effect of the L type are nifedipine, diltiazem, and verapamil. And the T type, we don't use them very frequently, called mifradil, flunarizine, and ethoxyxamide, and conototoxin. Because these three are very commonly known drugs. And what is PS mentioned in the above conductance regarding the speed with which it is conducting? The unit is given as PS, small t and capital S. Does anybody know what is the expansion of that?
No, sir.
Okay, so this is called picosiemens, symbol of picosiemens, which is an SI unit of electrical conduction, which is equal to 10 to the power of minus 12 Siemens. Okay? So Siemens is the symbol, the electrical conduction, electrical substance, and admitted in SI system. Name the hormones which increase the heart rate.
Catecholamines like adrenaline.
Catecholamines, very good. Then
Thyroid hormones.
thyroid hormones. Okay, so catecholamine, prothylene, aldosterone, ADH, and thyroxine. All of them increase the heart rate. Name the hormones which decrease the heart rate.
Acetylcholine.
Acetylcholine is a transmitter. Natriuretic peptides, neurokinin A, oxytocin, of course, acetylcholine also is the transmitter, which is also and can be classified as a. So, what are the drugs and chemicals which can alter the heart rate?
Beta blockers.
Beta blockers block or reduce heart rate. Other drugs increasing the heart rate. So you can classify drugs causing tachycardia, drugs causing bradycardia, isn't it? So digitalis causes increase in the stretch of heart muscle and accelerates the heart rate. This drug is used for low BP, but very high concentration can stop the heartbeat. Whereas atropine, which is a stimulatory drug, results in tachycardia. Beta blockers like indrol, propranolol, they cause mimicking the action of acetylcholine or blocking the beta receptor, beta 1 receptors, cause bradycardia. And pulmonary bronchodilators like isopropanol, ephedrine, cause tachycardia. And drugs like caffeine and nicotine, cocaine also cause tachycardia. What environmental factors can affect the heart rate? Anxiety, fear, the pressure surge, emotional stress, lack of sleep, stress, anger, fear, etc. All these things can alter the heart rate. What are the hormones released by the heart itself? Which is now becoming a drug which can be used for failing heart. No one is answering. What is ANP?
Atrial natriuretic.
Atrial natriuretic peptide. That's the hormone. Atrial natriuretic peptide. So it is produced by the atrial cardiac myocytes. Reduces the due to several mechanisms. Okay, it's mainly produced and stored by the atrial myocyte. It's also being produced in the ventricles, brain, suprarenal glands, and renal glands. What causes the release of ANP? Five major causes are distension of the atria, beta adrenergic stimulation, hypernatremia, increased angiotensin 2, and increases in endothelium. Okay, so all these things result in the release of atrial natriuretic peptide. Effects of atrial natriuretic peptide in vasculature and heart. Okay, it causes blocks the effects of catecholamines. While in the heart, it inhibits the, that is, in the vasculature, it causes a alpha blockade. So vasodilatation will occur. While in the heart, it inhibits hypertrophy by blocking norepinephrine stimulated protein synthesis. And it also exhibits cardioprotective properties related to the block cardiofibrosis and ischemic reperfusion injuries. What is BNP compared to ANP and what is the importance? Brain natriuretic peptide, very good. That is the expansion of BNP compared to atrial natriuretic peptide. What is the importance of BNP? Does it have any role in cardiac function? So it is produced by ventricular cardiomyocytes and works in a similar fashion to ANP, secreted by the ventricles of the heart in response to excessive stretching of ventricular myocytes, and level is increased typically in patients with left ventricular dysfunction. So when you, it is one of the becoming a very important marker to find out the degree of left ventricular failure. Okay, nowadays we do the BNP assessment, brain natriuretic peptide assessment, to find out the degree of LVF. Okay, so elevated BNP levels more than 125 picogram per ml in young and 450 picogram in old are thought to be indicative of poor left ventricular function and heart failure. Okay, it's one of the important markers, just like your troponin to assess the myocardial ischemia and infarction. BNP is a marker for LVF. Please remember that. What substances are produced by endothelial cells? And what are the effects of thyroxine on that? Endothelium, all of you know, is the inner lining of the vessels. So what are the substances that are produced by the endothelial cells? Idea? So endothelin 1, the potent vasoconstrictor that is produced by endothelial cells. Okay? They are mainly expressed when there is a vascular smooth muscles and each with carrying varying activity and activation. There are 4 types of receptors which are called endothelin A, B1, B2, B3, which are all G protein coupled receptors, and their activation is by intracellular free calcium. The activation of endothelin A receptors results in smooth muscle vasoconstriction. So whenever there is an injury or any damage to shrink or constrict the vessel, endothelin will be produced. The endothelin B causes release of nitric oxide from endothelial cells, which is a contrasting action to endothelin A. So the endothelins are main vessels, substances produced to cause either vasoconstriction or vasodilatation depending upon the requirement. And thyroxine is a hormone produced by the follicular cells of the thyroid gland. While it acts nearly on every cell, the most important function is to increase the effect of epinephrine, and that is the reason why you get a tachycardia when the patient has excessive thyroxine that is released in thyrotoxicosis. So through this permissive relationship, thyroxine increases the number of beta B1 receptors, thus indirectly responsible for increasing the cardiac output, both inotropic and chronotropic action. And clinical increases in thyroxine are associated with atrial fibrillation, which is a common cardiac arrhythmia. And elevated heart rates from thyroxine induce atrial fibrillation or other arrhythmias, which result in myocardial decompensation and heart failure. So IV thyroxine is indicated only during organ retrieval from brain dead donor. One of the management strategies of a brain dead donor is to supplement with IV thyroxine. That is the indication. Now, after this, some physiology that we have learned, we go to the last part of pharmacology, drugs which act on the cardiovascular system. So mention the drugs used in the treatment of acute and chronic heart failure.
Acute heart failure, diuretics, sir.
Mention all the drugs, whichever drug you want to say, you say that, then you will see the answers.
Yes, sir. Chronic heart failure, digitoxin, and beta blockers.
Okay, so AC inhibitors, angiotensin 2 receptors, beta blockers, interleukin receptor antagonists, diuretics, ivabradine. Then there are 2 drugs, new drugs like sacubitril valsartan, which is called ARNI. Can you tell me what is the expansion of this acronym ARNI?
Angiotensin receptor, norepinephrine inhibitor.
It's not norepinephrine, it's neprilysin inhibitor. Okay, first is angiotensin receptor, N for neprilysin inhibitor. This is a new drug which is very commonly prescribed by cardiologists to patients with reduced ejection fraction. Heart failure is now classified into preserved ejection fraction, failed or reduced ejection fraction. Okay. So sometimes nowadays you can see the cardiologists writing CF with PF, which is cardiac failure with preserved ejection fraction, and CF with reduced ejection fraction. That terminology has become very common now, and hydralazine with nitrate and digoxin. So what is this ivabradine?
It's a funny current blocker, sodium channel blockers, sir.
Sodium channel or potassium channel?
Sodium channels.
Okay, it's called hyperpolarization activated cyclic nucleotide gated channel. It is neither sodium nor potassium. It has a separate name called hyperpolarization activated cyclic nucleotide gated channel blockers. Okay, so these are all the various things which are acting on that and producing the various anomalies like sick sinus syndrome, atrial fibrillation, and neurohumoral, all these things. And how does this ivabradine differ from the beta blocker? Ivabradine is also supposed to protect the heart by reducing the heart rate. So in contrast to beta blocker, ivabradine reduces heart rate both at rest as well as during exercise also, with minimal effects on myocardial contractility and blood pressure and intracardiac conduction. Whereas the reduction in heart rate and increased diastolic filling time also has a beneficial effect on the myocardial relaxation. So that is why they prefer these two beta blockers to preserve the cardiac function as a drug of first choice. And this something about this new drug called sacubitril valsartan. This expansion of ARNI, I told you, it is the angiotensin receptor neprilysin inhibitor. And this is the first agent to be approved as a new class of drug. This is for patients with chronic heart failure with reduced ejection fraction. So HF with the REF or CF with RF, that is how it's also written. It is a combination drug. So sacubitril is a pro-drug that activates its activation acts on the neprilysin inhibitor. It is worked by blocking the action of neprilysin, which is the preventing the breakdown of natriuretic peptide, which is produced in the heart. So which leads to a prolonged duration of the atrial natriuretic peptide. So the natriuresis, reducing the sodium and volume overload by ANP, is having a prolonged effect by this particular blocking effect of this drug. And valsartan is a ARB, angiotensin receptor blocker, which works on the RAS system. And because the neprilysin blocks the breakdown of angiotensin 2, the inhibiting neprilysin 2 will accumulate angiotensin 2. And that is the reason why you have to give this ARBs along with that. Otherwise, you can simply use this alone, sacubitril, which will increase the level of or duration of action of ANP. But because bradykinin, angiotensin 2 also will accumulate, you have to give a drug like ARB to block the effect of that. So it cannot be used alone. So it always comes as a combination with these ARBs also. And another substance broken down by neprilysin is bradykinin. Neprilysin inhibition will also cause buildup of bradykinin. Therefore, sacubitril cannot be used with ACI inhibitors, where again bradykinin will be accumulating, which is the side effect. So patients who have been treated with ACI, there should be a time interval before you switch over to this combination of sacubitril and valsartan, okay, which is an ARB. So this is being a new drug, which is being now frequently used by veterinary cardiologists. You will have the opportunity to anesthetize patients who come for any incidental surgery with heart failure who are all on these drugs. So I thought you should be aware of this combination and what is the effect of that. What is the drug therapy for systemic hypertension? This is another pharmacology which all of us should know. How do you classify the drugs used for systemic hypertension?
A, B, C, D, sir. Alpha blocker, beta blocker.
Drugs act on the RAS system. AC inhibitors.
Okay, so you can classify them like this: thiazide diuretics, potassium sparing diuretics, beta blockers with increased sympathomimetic activity, angiotensin converting enzyme inhibitors. This is one class. The other is calcium channel blockers, which are classified into non-dihydropyridines and dihydropyridines. So non-dihydropyridines are diltiazem and verapamil, which are used mainly in arrhythmias, not as a regular antihypertensive. Whereas the dihydropyridines, like amlodipine, pilodipine, icardipine, all these things are regularly used. Then you have alpha blockers, which are doxazosine, prazosin, and central acting alpha 2 agonists like clonidine, methyl dopa. Methyl dopa now has now become almost reserpine or all older generation. And direct vasodilators like hydralazine and minoxidil. Hydralazine is still used in eclampsia patient, pre-eclampsia patient as an emergency treatment for reducing the blood pressure. So these are all the commonly used drugs. But to remember them easily, there is a easy mnemonic where you can say AAABCD. So the A stands for AC inhibitors, and these drugs usually end up with the last word pril. So lisinopril, enalapril. So if you read this pril in the last name, they are all AC inhibitors. They inhibit the angiotensin converting enzyme. They reduce the SVR and stroke volume, and that is the mechanism of action. ARBs end up as sartans. So losartan, valsartan, they are all blocking the angiotensin 2 receptors, and they also cause reduction in SVR and stroke volume. Then you have alpha blockers, which end as porcine, doxazosine, terazosin, and they reduce the SVR. Then you have beta blockers, which end as LOL. Not your WhatsApp LOL, laugh out loud, but this is metoprolol and labetalol. So they cause beta block receptors, decreasing heart rate and stroke volume. Calcium channel blockers, they end up as dipine, amlodipine, nicardipine, and they cause also reduction in SVR. Diuretics, they end up as IDE, furosemide, hydrochlorothiazide, and they facilitate diuresis, reduce the volume, and reduce SVR also. So this is the easy way to remember these drugs. Now, what drugs are used in the treatment of cardiac arrhythmias? Already we have seen, and how the action potential we have to know. So the class 1 drugs which act by sodium channel blockage, they are divided into class 1A, 1B, and 1C. 1A is a moderate action with quinidine and propanamide. 1B, lidocaine or mexiletine. Then there's a strong action, etinoside and propafenone. So these all act on the sodium channel. Class 2 drugs are beta blockers, metoprolol and lacenapril. And class 3 are potassium channel blockers, amiodarone and sotalol. Amiodarone is a drug which is very commonly used in emergency treatment. And it is one of the common drugs that may be given in the viva also for you to express your knowledge on that. And class 4 are calcium channel blockers, diltiazem and verapamil. So this picture will help you to remember all the 4 categories of the cardiac antiarrhythmic drugs. Volatile agents and cardiac function, they induce dose-dependent decrease in myocardial contractility and cardiac loading condition. This is the common effect of most of the volatile anesthetic agents, and that produces a balancing effect on the myocardial oxygen balancing. So this exposure to volatile anesthetic agent induces a phenomenon called ischemic preconditioning. Okay? That is being done by the volatile anesthetic agent exposure. And what are all the interactions between calcium channel blockers and anesthetic agents? Will it affect the activity of your muscle relaxant? Is there any reaction or interaction between calcium channel blockers and anesthetic agent? So inhaler agent decrease the availability of intracellular calcium, which in turn enhances the negative anotropic, chronotropic, and thromotropic effects of calcium channel blockers. So whenever the patient with calcium channel blocker treatment comes, be careful with your inhalation agent. They can potentiate all neuromuscular blocking agents, especially impair hypoxic pulmonary vasoconstriction and mildly increase intracranial pressure also. And calcium channel blockers, can it be used during the treatment of malignant hyperthermia? Will it aggravate malignant hyperthermia? Because in malignant hyperthermia, there is a rigidity produced by stiff contraction, isn't it? What is the pathology in malignant hyperthermia?
Rhinodacin receptor mutation.
Mutation. Mutation of the rhinodacin. Okay. So they are contraindicated during treatment of malignant hyperthermia due to increased potential for cardiac collapse after concomitant administration of both dantrolene and calcium channel blocker. So we have to be very watchful about that. What is phentolamine and what are its uses?
Selective alpha, non-selective alpha blocker. Selective alpha blocker. Alpha 1.
It's an alpha adrenergic receptor antagonist used in dentistry for reversal or more accurately for limiting the duration of soft tissue anesthesia after non-surgical dental procedures by promoting local vasodilation and thereby accelerating the rate of systemic uptake of local anesthetic away from the site, not used by us. And it also used to manage hypertensive crisis associated with pheochromocytoma, commonly in combination with beta blocking agent to attenuate the increase in heart rate. So, what is the other drug used in preparation to control the blood pressure?
Phenoxybenzamine.
Phenoxybenzamine, that is more common. Okay, that is a more non-selective alpha blocker, and which is the alpha blocker used in the medical management of BHP, that is benign hypertrophy of the prostate.
Prazosin or tamsulosin.
Very good. These are the alpha blocking the tamsulosin used for management of benign hypertrophy, which has a highly selective action on the alpha receptor. To prescribe this should be continued preoperatively. You should not discontinue this suddenly. Okay? And should beta blockers be continued before surgery and anesthesia?
Yes.
Yes. Sudden withdrawal of beta blocker is very, very dangerous. An important consideration regarding beta blockers is strong evidence recommending that patients should continue their usual home dose prior to anesthesia and surgery, and you should not suddenly withdraw beta blocker if the patient has been on beta blocker for a long time. Why? What is the
Rebound
reason?
hypertension.
Rebound hypertension, and also the upregulation of receptors are very high. The patient can go in for sudden heart failure and myocardial ischemia. Okay? That is the important risk of that. What will happen if they are stopped abruptly? That is the answer. Discontinuation of beta blocker is associated with rebound hypertension in tachycardia, which can lead to myocardial infarction and ischemia. What causes these effects of beta blockers are withdrawn? Of course, this is increased sympathetic activity as a probable reflection of adrenergic receptor upregulation. This is the main mechanism during the symptoms of periods of sympathetic blockade. This beta regular receptor upregulation leads to hypersensitivity to circulating catecholamine and leads to the negative effects. Can beta blockers be used in asthmatic patients?
No, sir.
Cardioselective.
Cardioselective can be used. Very good. Non-selective beta blockers should be used with caution, like propranolol should not be used. Whereas selective beta blockers are still elicit some beta adrenergic, but less than non-selective. So beta 2 agonism can be used in the treatment of asthma, and beta 2 agonist effects of the beta blockers can be counterproductive in acute treatment of bronchospasm. What are the effects, adverse effects of beta blockers? This is more to know the drugs which can be used, which cannot be used. So adverse effects are generally overextension of pharmacologic effects, including bradycardia, orthostatic hypotension, AV conduction delay, and hypotension. Okay? And it can be bronchospasm with the non-selective drugs. And because compensatory glycogenolysis is blunted by beta blockers, the warning signs of hypoglycemia will be masked. And there is relative contraindication in poorly controlled diabetic mellitus also. And beta blockade during preoperative period alone can blunt the effects of surgical stimulation, and some used to achieve what is called opioid sparing effect. But beta blockers should not be started just before the surgery. It should be done well in advance. And what will happen if alpha 2 agonist drugs are withdrawn abruptly, like clonidine? If you are using it as an antihypertensive, supposing it is withdrawn abruptly, what will be the effect? That will also produce severe rebound effect. Abrupt withdrawal, which is like clonidine or guanfacine, a rebound hypertensive crisis itself can happen. Okay? The benefits of using alpha 2 agonist in anesthesia.
Pheochromocytoma before
Adjuvant.
Benefits are other than control of hypertension. Are there any benefits?
Analgesia, sir.
They can produce analgesia as well as
Anxiolysis.
and osmotic
less
diarrhea.
respiratory depression, and it will be useful in cases like fiber optic intubation, feeding lesser doses of opioids, and also they have preoperative anxiety and emergency delirium are reduced by usage of alpha 2 agonists. Okay, these are all non-cardiovascular or non-hypotensive effects. What are the anesthetic implications of diuretic therapy? Whenever a patient is on chronic electrolyte abnormal, very good. So adverse effects are hypokalemia with metabolic acidosis. Potassium sparing agents may produce hyperkalemia. Diuretics can cause dehydration and hypovolemia. Thiazide diuretics will aggravate glucose control, and patients may not have adequate glucose control. They also prolong neuromuscular blockade with non-depolarizing neuromuscular blockade agent. So patients, if they are on thiazide diuretics or other diuretics, these are all the effects which we have to be aware of. And many long-term hypertensive patients have a mass state of hypovolemia. So during induction, they may have a sudden fall in blood pressure. So you have to be very careful. What are the anesthetic implications of ACE, angiotensin converting enzyme inhibitors?
Refractory hypertension.
Refractory, very good. Refractory increased, and the angioneurotic edema, and also they can cause chronic cough clinically because of excessive bradykinin accumulation. How is the angioneurotic edema or angioedema caused by that? Is it because of histamine release or something else?
Bradykinin.
Bradykinin is a receptor antagonist. So that is a drug of choice for treating the angioedema, not your usual steroids and antihistamines. So that will not respond. So bradykinin receptor antagonists, they are called icatibant or kallikrein inhibitors. Okay, that may provide the treatment for that. How is the refractory hypotension caused by ACE treated? Your usual ephedrine and phenylephrine, will it be helpful? Or you
No, sir. It won't be helpful. Vasopressors can be used.
Vasopressors like phenylephrine have been used without desired clinical response to hypertension. So options are vasopressin, epinephrine, or norepinephrine. So if a patient has continued ICE and you have now forgotten to stop it or give instruction to stop it, and patient develops severe hypotension, straight away treat them with either small doses of epinephrine or epinephrine and vasopressin, and not your usual drugs like ephedrine and vasopressin. Okay, I mean phenylephrine. So that is the overall bird's eye view of all the components of cardiovascular basic physiology, basics that you have to know. And any questions or any doubts you want to ask? So nothing to. You have to remember the important changes that happen in ECG, and ischemia and infarction. Right. Amachi, are you there?
Actually, I wanted to add two more items, sir. One is levosimendan is also recently asked in question.
Yeah, some of the drugs are not included, like phosphor. Also coronary vasculature has not been included. I have to include them.
Yes, sir. And the other thing is Frank Starling
Equation, yes.
yes, sir, equation and the Treppe phenomenon. Rate dependent increase in the inotropic. Yeah, these are all. Sometimes the examiners are asking in practical.
Yes, I will include that and for the suggestion.
Yes, sir, just for completion sake. Thank you.
Okay. Okay. Shall we sign off then?
Yes, yes, sir.
Yes, sir.
Yes, sir.
Thank you very much, sir. Thank you.
Thank you,
students.
sir.
Thank you, sir.
Thank you, sir.